Right. Just focusing still on patient and public participation. Other comments or queries at all for Victor and or Jane? No, well, actually, Victor, can I just say thank you again for taking on the chairmanship of the Task and Finish group and for the way in which that's fed into this report, for the revision of the policy which we will apply across the organisation. But also it's an area in which the board will continue to take a strong interest and wish to oversee developments as they occur. Because I think
thank Michelle to both led the blind with me on this. Well. Thank you very much, Michelle.
Yes, thank you indeed, Michelle. Okay, well, maybe then turn to the next item on the agenda, which is the reports from committees. If I could just take them in turn. Yes, of course, Jane. First, David on Commissioning Committee.
So nothing to add to the report, Malcolm. I think just one small but important point of governance, which is that we have previously delegated primary care commissioning to 3 CCGs in the Manchester area. We have previously approved, I think last time, the merger of those 3 CCGs. The net result is we now formally need to delegate primary care commissioning to the new merged entity. The Commissioning Committee considered this yesterday and recommends it wholeheartedly to the board.
May I ask the board please to endorse that?
Thank you.
David.
Nothing else.
The next, Investment Committee, Myra.
I don't think there's anything to add, Malcolm.
No, thank you again for the report. May I come back to specialised services and just ask Joanne, audit and risk?
Nothing to add, thank you.
Okay, so may we come back to specialised services? Noel, over to you.
Thank you, Malcolm. I would like, if I may, just to amplify on one of the points made in the report to the board of the discussion held at the Specialised Commissioning Committee on the 23rd of February. Not least because we have received today a petition on behalf of a number of patients which addresses the decision made by both the Specialised Commissioning Committee of this board and the NICE board on the 15th of March concerning our strategy and approach toward the future of specialised technologies and specialised drugs. So I'll just amplify, if I may, a few of the reasons why we came to the conclusion that we did. Not least because in the consultation process, which was pretty extensive and concluded on the 15th of January, we had to balance a number of perspectives, not only those perspectives received in the consultation process, but also the affordability issues over the next 3 years for the NHS itself. And the conclusion we came to in trying to define the right approach to what's known as the adoption of technologies and highly specialised technologies, but in reality that means specialised medicine, specialised devices and specialised treatment pathways, was really based on 4 prime objectives. The first of which was to get quicker access for patients to the most cost-effective new treatments that are coming forward, and they're coming forward very fast. Secondly, more flexibility in the way that we adopt those technologies into mainstream commissioning, which are both cost-effective but also high in their ultimate budget impact. Thirdly, to get a lot more clarity for patients and the pharma industry generally about the level at which treatments for very rare conditions would receive automatic funding. And fourthly, to put on a much clearer footing how we're going to approach these decisions for the next 3 years. So where we concluded in our approach between NHS England subcommittee of the board and NICE really establishes 3 new pillars for access to specialised technologies. The first is the fast-track appraisal process, which means that there will be a shorter, lighter touch approval process for treatments which have a cost per quality of life year of under 10,000, and that those will be introduced after 30 days rather than the traditional 90 days that preceded it. And that will enable a lot of patients to get access to drugs that qualify under that quality within a much faster period of time than they had before, which is very positive news. In addition, the technique of fast track may well be adopted by NICE in other ways, and that lighter touch appraisal process could be of benefit in a much wider range of products than today. The second pillar of the new approach is the budget impact test. I should make the point right at the outset that it's not a cap, as it's been presented in a number of different fora. It is, in fact, a test. It's a test for technologies that pass the NICE value assessment, but where the budget impact exceeds £20 million in any of the first 3 years. It's not a cap, it is a trigger, because it automatically triggers a process for the NHS to engage with pharma on finding ways to economise on the cost of new drugs that are coming forward. And it really is important for us to engage fully with pharma in working out ways to bring down the costs of some of the most crucial treatments to some of the patients who need these technologies the most. And that is why it is a trigger and a test, not a cap. It doesn't mean that drugs over 20 million in any one of 3 years will not be funded. It simply means that we engage in a process where we will seek to come to a better cost structure with the pharma industry than we have ab initio, as it were. The third pillar is highly specialised technology appraisals, where we have now introduced what I think is a very positive benefit for patients, which is a new quality threshold of 100,000 per quality of life year for drugs that come through the highly specialised technology assessment programme. That does pick up a number of submissions that we received in the consultation process. It responds to those in a positive way, and will result in progressive advantage to patients for drugs that come in under the 100k threshold. So overall, I have to say that the consideration given to this really complex and immensely important change in our policy was extremely thorough. It considered a huge amount of input that we'd received from the consultation process. We'd had many pre-discussions with NICE beforehand on the right configuration of these three pillars. But ultimately, the committee acting on behalf of this board, and indeed the NICE board subsequently, have approved this as the way forward. It will persist for the next 3 years. We do have the opportunity to review it again in 3 years' time, but until that time, this proposal has been accepted by both boards as the way forward. And notwithstanding the way that the decision's been presented, as I said, in a number of fora, I think there are immense positive benefits to the way that many of our rarer treatments are going to be funded as a result of the policy framework we've developed.
Thank you, Noel. May I just invite any questions to Noel? Paul?
Just one point of clarification, I think, to make sure that there are no misunderstandings about the highly specialised technology thing. So we consulted on 100,000 as the limit, as you quite rightly said, Noel. In response to the feedback we had, we varied the proposal that we were putting forward such that those that offered the biggest quality life gains actually were able to work to a higher limit than 100,000, up to 300,000 for the most advantageous drugs. We think that will give a more balanced approach to trying to bring in the most effective and the most high-impact drugs. Just wanted to make that clear, I think.
Thanks.
Thank you, Paul. Well, thanks, Noel. I think it's clear around the board that there has been some concern about the proposals, that it's not simply been those representing patients, but also the industry. Certainly on that side, I see the way in which we've been working closely with the industry on the life sciences industrial strategy as a major bridge towards a new relationship for the future, and to opening up of the NHS in its relationships with the industry around the genomics that we talked about this morning, around clinical trials and on many other fronts. So I see your report this morning as part of the bigger picture of resetting relationships, understanding that drugs cost us something like £16 billion a year, and it's important to get the costing and the pricing and the application right. Right, well, on the basis that there are no further issues that people wish to raise with you, and on the basis that we have reached the end of the agenda, may I, with your permission, draw the meeting to a close, having first of all passed the usual resolution, because we need now to proceed to the private meeting of the board. Thank you. The meeting is closed.